So thank you so much to Barbara and the whole TCAPP organization, and it's a real pleasure to be here with all of you today. I was asked to sort of give an overview of Ehlers-Danlos syndrome to sort of lead things off for this morning. Not sure where the best place to stand is. Maybe it's over here. Okay. So we typically think, and I have to thank Dr. Graham for this illustration from one of his wonderful publications. We think about joint hypermobility, and I would venture to say that 99% of the physicians out there who know about Ehlers-Danlos syndrome think about joint hypermobility as really the manifestation of Ehlers-Danlos syndrome. And we look at the Beighton score, which is a 9-point scale, and we say a person has a level 4 or 5 score on the Beighton scale. And then we classify them as having joint hypermobility. But the truth is, what we've come to realize over the last, I would say, maybe 5 to 10 years, is that Ehlers-Danlos syndrome is very, very much more than this. And there are many children and adults who are suffering from complications that involve multiple organ systems that have absolutely nothing to do with the joints. So this is a really, truly multi-system presentation, and affected persons have both musculoskeletal, dermatological, neurological, cardiovascular, gastrointestinal, and immunological manifestations that can, as Barbara was saying, profoundly influence their quality of life. Now, there are multiple different types of Ehlers-Danlos syndrome. The most common ones are the first 3 that are listed on this slide. The classical, which in the old nomenclature were types 1 and 2, and classical Ehlers-Danlos syndrome is caused by type 5 collagen mutations. The hypermobile type, or in the old nomenclature type 3, the gene is still unknown. And then the vascular type, which used to be called type 4, is caused by mutations in type 3 collagen. Beyond that, there are a number of relatively rare, really quite rare, disorders, including what's called the kyphoscoliotic type, which is caused by mutations in lysyl hydroxylase, the enzyme lysyl hydroxylase. The arthrochalasia type, which is caused by mutations in type 1 collagen, and dermatosparaxis, also an alteration of collagen processing. This is an enzyme that actually cleaves the N-propeptidase from the procollagen molecule in type 1. And tenascin X deficiency resembles the hypermobile type of Ehlers-Danlos syndrome. Dr. Ann DePapp and her co-worker, Dr. Malfate, wrote an article recently, this was in Clinical Genetics in 2012, describing Ehlers-Danlos syndrome. They called it a disorder with many faces. And in this excellent review, they gave another list. There's some additional recently described subtypes of Ehlers-Danlos syndrome, including this musculocontractural type, see here, which is an autosomal recessive form caused by the CHST14 gene. And all of these that are down here in this list are relatively rare, but we will see them as those of us who are seeing lots and lots of patients with hypermobility encounter additional patients. Eventually, I would assume that some molecular biology laboratory is going to come up with a panel that will be able to send DNA off and test for these various different types of molecular defects. Now, also from Dr. Ann DePapp's lab is this analysis, which is very, very interesting. This was published in Human Mutation in 2012. And they found that if they really very carefully defined the type classic type of Ehlers-Danlos syndrome, they were able to find type 5 collagen mutations in over 90% of the patients. So just to give you a little bit of the history of how the classic type initially came to be defined, in the older nomenclature, type 1 was called the gravis type of Ehlers-Danlos syndrome, and these were the people who had the just tremendously stretchy skin and really, really fragile skin. So they had a lot of scarring over their shins and their knees. A lot of problems with wound dehiscence. And so that was the gravis or most severe type. Then type 2 was the Midas type, or relatively mild type. Those people had mild skin findings, also with the joint hypermobility. And then type 3 was what became the hypermobile type, relatively little in the way of skin findings. And when the Villefranche nomenclature was put together, they lumped types 1 and 2 into the classic type. And this paper from Dr. TCAPP now suggests that really if we limit the classic type to what we used to call type 1, we can find type 5 collagen mutations in almost all of those people. And maybe it makes more sense to lump what used to be called type 2 in with type 3 and call those the hypermobile people. We won't really know about that until we have molecular definition of hypermobile Ehlers-Danlos syndrome, and I believe there are going to be additional subtypes that we will identify when we start getting good molecular definition. So that's something that's really a very big, important, outstanding question for all of us who care for these patients. Now, Dr. Graham has offered us this questionnaire for joint hypermobility, and the questions he puts to people: can you now or could you ever place your hands on the floor by bending forward with your knees straight? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you do party tricks, amusing your friends by contorting your body into strange shapes, or could you do the splits? And questions about shoulder and kneecap dislocation, and do you consider yourself to be double jointed? There is this question outstanding in some people's minds, I would say. In some of our minds, this issue has been resolved, but there's a question about joint hypermobility and joint hypermobility syndrome and their relationship to Ehlers-Danlos syndrome. And Dr. Graham and Dr. Tinkle and others wrote a paper in 2009 suggesting that really these are the same disorder, and I believe this to be true. They have overlapping criteria, but are still not defined exactly the same. And it was interesting. I heard Dr. Murray speak yesterday at the Ehlers-Danlos National Foundation meeting, and she was saying that depending on which specialist, in which center, in which city you go to, with exactly the same presentation, you will wind up with a different diagnosis. If you go to see a rheumatologist, you might be told you have joint hypermobility syndrome. If you go to see a geneticist, you may be told you have the hypermobile type of Ehlers-Danlos syndrome. And then she said, well, you know, even within the same clinic, in the same hospital, in the same city, depending on which physician you see, you may come out with a different diagnosis. So this is still, again, something that we need to develop a consensus on and really do some good professional education about. So for joint hypermobility syndrome, the major criteria include a Beighton score of 4 or more, and arthralgias for more than 3 months in 4 or more joints. And the minor criteria include lower Beighton scores, 1, 2, or 3, arthralgias in 1 to 3 joints or back pain for more than 3 months, spondylosis or spondylosis and spondylolisthesis, dislocation or subluxation in more than 1 joint or in 1 joint on more than 1 occasion, Soft tissue rheumatism with more than 3 lesions, so epicondylitis, tenosynovitis, bursitis, and so on. Amarphanoid habitus, skin findings, which would include stretch marks, hyperextensibility, very thin skin, or atrophic scarring. Drooping eyelids, myopia, antimongoloid slant in the eyes, and varicose veins, hernia, or uterine or rectal prolapse. And the Brighton criteria, and this is another unfortunate thing, that Brighton and Brighton sound so similar to each other, and I think it really is, it's very confusing. But the Brighton criteria that were established for the diagnosis of joint hypermobility is the presence of either 2 major criteria, 1 major and 2 minor, or 4 minor criteria. And if a person has an unequivocally affected first-degree relative, then we can establish this diagnosis in the presence of 2 minor criteria. Okay. So just to go through the various organ systems and the kinds of manifestations that we see in our patients, obviously, for the musculoskeletal, the joint hypermobility is the first thing, and joint subluxations and dislocations that go along with the hypermobility. Tendon and ligament ruptures are common, as are stress fractures, and our patients are at increased risk for decreased bone mineral density. We see a lot of degenerative disc disease, even in teenage children. We start seeing degenerative disc disease at an incredibly young age. Meniscal tears, chronic pain syndrome, which is obviously why we're all here today, and the issue of myofascial pain, which can be a major contributor to chronic pain. So I think this is how many of our patients feel when they wake up in the morning. They're just facing a day of unrelenting discomfort and disability related to pain. Headache is a major cause of pain in Ehlers-Danlos syndrome and other hypermobility syndromes. These may be migraines, they may be low-pressure headaches, they may be high-pressure headaches. People have pain because of myofascial issues, sinus pain, TMJ, and dental pain. There are lots and lots of causes for headache in this population. Now, some of the causes of musculoskeletal pain in hypermobility are related to the joint laxity. The joint laxity predisposes to acute injury. People are more disposed to sprains. Because the tendons and ligaments are not holding the joints together properly, the muscles step in to try to do that job. And so you have muscle spasm that results as a way of literally trying to hold the body together. And myofascial trigger points are also, they develop in response at the myofascial junction where the muscles join up with the tendons. We also see nerve impingement, which may result either from disc disease or from joint laxity, and this can cause both muscle spasm and neuropathic pain. Now, in the skin department, we look at skin that is soft, it's stretchy, it's translucent. We can see the veins through it very easily. We see easy bruising and atrophic scarring. And just to illustrate some of these features, this is the atrophic scarring, stretchy skin, and striae. Now, our neurologists will recognize headache, as I mentioned earlier. Spondylolisthesis is common in terms of instability in the spine. And Dr. Henderson will address these issues in greater detail a little later in the day. We see craniocervical instability and cervical instability, Chiari-1 malformation, and if not frank Chiari malformation, then low-lying cerebellar tonsils. There are many people who present with increased intracranial pressure and with leaking of the CSF. This is an interesting paper that was published in 2012 in Pediatric Physical Therapy documenting increased problems with balance in children with hypermobility. In this paper, 20 children with hypermobile Ehlers-Danlos syndrome and 24 control children were assessed clinically for hypermobility and balance. They were questioned about their participation in activities of daily living and asked to keep diaries of their pain and physical activity. And it was quite striking. The data are really pretty dramatic in terms of the diminished participation in activities of daily living, as Barbara was mentioning earlier, their decreased physical activity, their levels of pain, and also their problems with balance. So it seems that proprioception can really be a significant issue and may be one of the contributors to falls that we see in many of these patients. And this is a paper from Dr. Shavink, also published in the last year. This is a 2013 article looking at 50 consecutive patients with spontaneous CSF leaks. And in this population, 18% of them, 9 patients out of 50, were found to have a hereditary disorder of connective tissue that was previously unrecognized in many of these patients. Now, another very important issue related to the nervous system is autonomic dysfunction. And you'll hear more about this later as well, but postural orthostatic tachycardia syndrome and neurally mediated hypotension, sleep disturbances are critical, really a very, very important consideration, and one of the main reasons I believe that many of our patients present with such disabling fatigue. Gastrointestinal motility disturbances and other GI issues, which you'll hear about from Dr. Collins in a little while, and difficulty with temperature regulation. So we've seen patients who have chronically low temperatures, chronically high temperatures, temperatures that fluctuate back and forth, up and down, and just are really unable to modulate their temperature regulation. So this is another aspect of autonomic dysfunction. And this is just a slide to remind us all about the many, many manifestations. It's not simply the orthostatic tachycardia or hypotension that can result from autonomic dysfunction. Literally, we have involvement of so many, virtually every organ system in the body can be affected by autonomic dysfunction. And Dr. Posinki yesterday gave a really wonderful talk about sleep regulation in Ehlers-Danlos syndrome and how many of our patients do not have good restorative sleep. And in many cases, we'll send them for a sleep study, and the sleep architecture, which is the word people use to describe how much time patients spend in various stages of sleep, is completely deranged. It's just, and the amount of time that they spend in that good, deep, restorative sleep is simply inadequate. And so it's not surprising that people are tired. You know, I often tell my patients there's a reason that people use sleep deprivation as a form of torture. The human body is not designed to function without sleep. So our sleep colleagues, though, need education about this also, because we send people for sleep studies. We say they're exhausted. We say they're looking for, we're looking for changes in the sleep architecture. And we get back a report that says there's no obstructive apnea. It's like they don't even address the question, you know, and then, so it's not helpful. And when you look at the report, it's very clear that the sleep architecture is completely deranged. But, you know, so we have some work to do in that department also. So really, the effects of sleep deprivation, irritability, cognitive impairment, memory lapses, so many of our patients talk about brain fog, impaired moral judgment, up to severe hallucinations, attention deficit, impaired immune system, autonomic exacerbation of autonomic issues, decreased reaction time, tremors, aches. So many of these symptoms that our patients present can be attributed to lack of sleep, but the major one is the fatigue. So many of my patients have said to me, look, doc, I can deal with the pain, but the fatigue is what's really taking me out. You know, I can't function because of the fatigue. So that's another major, I think, box that we need to deal with. Now, in terms of the cardiovascular system, we see mitral valve prolapse, aortic root dilatation, which usually does not progress. In the classic and hypermobile type, the aortic root dilatation is not a major issue. In the vascular type, the aneurysms that typically develop are aneurysms in the medium-sized vessels. These are most typically in the abdominal area, the splenic artery, hepatic artery, and so on. We have seen carotid and iliac artery aneurysms, and this is obviously a life-threatening potential complication. Venous insufficiency is a very interesting phenomenon. We've recognized it for years as a contributor to the POTS type phenotype, and for many years, I just was thinking that the valves and the veins, which are made of connective tissue, were simply inadequate, and we were getting increased pooling in the legs as a result of that. But with the recent publication of issues related to venous insufficiency from the brain, from the head, I've been rethinking that idea, and it may be that there is some fundamental problem with venous function in this disorder that we have yet to really elucidate. And there's also a phenomenon called fibromuscular dysplasia, which is seen in a subset of patients with joint hypermobility, and we still don't really know whether this represents a separate clinical entity or is a subtype of Ehlers-Danlos syndrome, and that is all going to sort of wait on the identification of genes. Now, the GI department, you're going to hear about this in a lot of detail from Dr. Collins, so I'm not going to go into much about this except to say that there are many, many complications involving the GI tract and many causes of GI pain. So dysmotility, esophageal spasm, gastroesophageal reflux, constipation, irritable bowel syndrome. Sphincter of Oddi dysfunction is an interesting phenomenon that needs to be thought of because many times it doesn't come up in the differential diagnosis. And abdominal wall hernias can all contribute to abdominal pain in our patients. Now, in the immune department, common variable immunodeficiency, multiple allergies, and mast cell activation disorder are all features. The mast cell activation disorder is something that it really in the last 2 or 3 years has only just recently come to our attention. But it's a very interesting phenomenon. It's a cause of inflammation. The release of histamine by mast cells can cause rashes, hives, flushing, and a significant amount of gastrointestinal discomfort, chronic diarrhea, and treatment for mast cell activation, which includes antihistamines and cromolyn sodium to stabilize the mast cells, can significantly improve symptoms in many patients. It's been interesting to me. There are some patients in whom, bless you, so many symptoms are resolved by treatment for mast cell activation disorder that you really wonder if there are other patients where the mast cells are contributing where we haven't thought about it because they don't have those cardinal manifestations of the flushing and the redness. I had one patient who came in and said her fatigue was just incredibly improved when she went on antihistamines and the cromolyn sodium. So we did a survey looking at the manifestations, the extramuscular manifestations in Ehlers-Danlos syndrome in 300 consecutive patients that were seen at Greater Baltimore Medical Center. This was a survey that was done by two of the medical residents working with me at GBMC. And our goal was to ascertain the prevalence of reported extramusculoskeletal systems in the series of patients seen consecutively over 3 years, and to better characterize the burden of disease in patients with Ehlers-Danlos syndrome. And at that time, there were 2 articles in the literature. Since then, there have been a few more. Our sequential cohort included 18 patients with hypermobility who were less than 18 years of age, and 32 patients with the classical type. Now, I should say, at the time that we did this survey, this was before Dr. TCAPP's paper suggesting a more rigorous definition of the classical type. So there are probably some patients, maybe even as many as half of the patients who are in the classical type, who we would now characterize as being in the hypermobile type. So I'm not sure of the validity of this distinction anymore. But the bottom line was really that we had no clinically relevant differences between the hypermobile and classical patients. So I think you can look at the group as a whole and feel that they're fairly representative of either definition, either the hypermobile or classical diagnosis. Of the patients who were diagnosed as hypermobile, only 4% of them were male. In the classical group, only 15% were male. And we believe that one of the reasons that so few males come to our attention is that there is the difference in the hormonal milieu and the difference in the ability to build muscle, and that stabilization of the joints by muscle in men is protective against at least the joint hypermobility syndrome symptoms and the pain, musculoskeletal pain, that is an immediate sequelae of the joint hypermobility. So the Beighton scores on average in our group were 7 for all age ranges, except for those over 50, where we saw a slight decrease in the Beighton down to 6. We used the brief pain inventory. This is a form that people fill out to indicate how much pain they're experiencing at the present time, over the past week, and at its most severe and on average. And on average, our patients tell us that they're living with a pain score around 5, and that their worst pain is typically between 7 and 8 on a scale of 1 to 10. I must say, this is just simply unacceptable. You know, this level of pain is a level of pain that severely interferes with quality of life. It interferes with sleep, leads to worse fatigue. So just to reiterate the reason we're all here, this is what an issue that is really very much in need of addressing. We also assessed the performance status with the Karnofsky Performance Status Scale. This is a series of statements. We asked the patients to circle that statement which best reflects their current status, with 100 being I feel normal, no complaints, no evidence of disease, and on a 10-point scale down to 10, where I have fatal processes that are rapidly progressing and I am near death. So we've had a few patients come in at 20. By the time people get here, they're not traveling to the doctor. So, the average, the mean Karnofsky score here was for both the hypermobile and classical type very close to 70. And this says, so most of the people who get to my office say, I am able to care for myself, but unable to carry on normal activities. Now, these are percentages in terms of palpitations, about 50 to 60%, syncope, 26%. 66% of the patients reported dizziness, and 37 to 40% reported chest pain. Dysphagia or difficulty swallowing in around 11 or 12%. More than half of the patients tell us they're experiencing nausea. Emesis, this was one of the few where we had a difference between the classical and the hypermobile group, but I don't really know what to make of this distinction, but a large number of patients are experiencing nausea. Abdominal pain in 46 to 56%. Constipation is a very common problem, as is diarrhea. And you've got 10% here having fecal incontinence, which is a very large number for a very serious and difficult complication. In terms of urinary symptoms, about a third are having urinary urgency, and 21 to 26% are reporting urinary incontinence. About 40% with urinary frequency, and about 10% with recurrent urinary tract infections. Neurologic symptoms, 70% are reporting headaches. So this is huge. And 52 to 56% reporting migraines. People distinguish between their typical headaches and their migraine headaches. The migraine headaches are the ones that take them out. They have to go to bed. They have to be in a dark room. They are completely unable to function. Excuse me. Dr. Pasinki said yesterday he thinks these numbers are low because the people he sees are actually, more of them are experiencing insomnia. But in our group, 65 to 77% reported insomnia. And again, this comes back to the issue of proprioception. Falls are related both to joint instability, proprioception issues. There are many reasons why our patients fall. Tremors in about 25%. The seizures are an interesting issue because many times people present with what look like epileptic seizures, but their EEGs are completely normal, and so they get diagnosed as pseudo-seizures or non-epileptic seizures. And I think often these are related to a high cervical myelopathy. Dr. Henderson, you may comment further on that a little later. And numbness due to nerve compression, either because of unstable joints, disc disease, instability in the spine, and so on. So there are many, many reasons for these multiple neurologic symptoms. Tinnitus is a common presentation for craniocervical instability. About 15 to 17% reported hearing loss. Many of our patients have floaters in their eyes, and hyperopia was present in 16, 17%, and myopia in about half. Now, psychiatric symptoms, many of our patients are reporting mood swings. People who are not feeling well just don't feel like participating in society, and this is a cause of withdrawal. Anxiety, I believe, is a really common presentation for POTS. And so, we see people who just report these tremendous panic attacks, like heart beating out of their chest and just feeling like they're going to die. This is huge anxiety. It's not feeling a little anxious. And depression is also very common and often quite situational, because of the multiple losses that our patients experience because of their chronic illness. And problems with attention were reported in 13 to 14%. The temperature instability, as I mentioned earlier, and some problems both with weight gain and weight loss in a small number. So finally, in terms of the dimensions of this disorder and the prevalence, again from Dr. Graham's publication in 2003, he reported that up to 45% of all patients referred to general rheumatology clinics satisfy the Brighton criteria and may therefore be said to have joint hypermobility syndrome, indicating this is a very common at-risk phenotype in the community at large. We had some conversations yesterday, and I think the joint hypermobility is obviously out there. Not everybody who develops joint hypermobility is going to develop the symptoms that we're seeing here. And distinguishing between those people, what is the reason that some people get into trouble and other people manage perfectly well with their joint hypermobility through a whole average lifespan? That's something else that's really important for us to figure out, because if we know what the triggers are, we can try to prevent them and develop rational therapies for intervening when they do. The number several of us came up with and kind of talking around about it, I think that this is, we're going to find, if we really look closely, about 1% of the population is suffering from this constellation of symptoms. Albert Schweitzer said, "Pain is a more terrible lord of mankind than death itself." This is why we're here today. And another thing I think it's very important for us to remember is that it's not just EDS. EDS in and of itself does not cause the pain. There's an underlying something that's going on that we need to recognize and treat. And so the patients who are told, oh, it's just EDS, we need to get beyond that and be more rational in terms of our management for them. So a warm thank you to Christy Hackinson, the genetic counselor who's working with me at Greater Baltimore Medical Center, Dr. Anil Menke and Saqib Beg, Dr. Henderson, who's been a wonderful colleague and collaborator, and Dr. Graham, and all our patients and their families. And thank you very much for your attention.